And so with that, Dr. Evidente and I will now do a Q&A and we'll take a lot of questions. I think there was a question here from this gentleman.
That would be too funny. You were talking about doing a spinal tap for diagnosis of Alzheimer's.
Yes.
If you had a subject in front of you who was 60 years old and you were doing this, would you also do alpha-synuclein?
So I am a big fan of the SynTap test from Amprion. You're asking a very nuanced question.
Thank you.
And I tell you that because a lot of people think that's exactly what we should do. That if we're checking amyloid and tau, we should be checking for alpha-synuclein. And why is that? Because it turns out that up to a third of people with Alzheimer's, a third. This is not rare. It's not a couple. We're talking a third of people with Alzheimer's, meaning amyloid and tau, also have alpha-synuclein. So the answer is that's a feasible thing. If the needle's in the back, once the needle's in the back, doesn't matter. I can take 5 cc's or 20 cc's. Amprion only needs 1 or 2 cc's anyways, milliliters. So my answer is maybe, and I think that might be the future.
Well, what is the downside of doing it?
There's no downside. There's no down. Like I said, once the needle is in the back, there's no downside. The question then is, but that has not become standard practice in clinical routine medical care.
That you would do it and you would actually hold the specimen, just do the test for Alzheimer's and hold it.
Yeah, you could do that. Yes.
And then know that it was there, and if symptomatology presented along the lines of PD, then you could go back and test it.
Absolutely. In fact, it's interesting. Your comment is so on point. You guys are all aware of the PPMI, right? Parkinson's Progressive Markers Initiative, PPMI. I'm actually the doctor that does the spinal taps for my Parkinson's colleagues in our clinic because I'm really good at doing spinal taps. And guess what they're checking? We do the spinal tap. They're checking for alpha-synuclein, amyloid, tau. So they're doing in PPMI what you're already proposing. That scientific is going on. But what you're asking is, will it become part of routine clinical practice? And the answer is not yet, but there's a lot of discussions about doing just that.
Thank you.
Mm-hmm. Yes.
Two questions. One, if we discover that we have the propensity to get Alzheimer's, what do we do about it? There's nothing to do about it. Why would we want to know?
So that there is that kind of nihilistic, pervasive prescription. That's why brain health is so popular, because we want to empower ourselves to do something to mitigate our risks. So I'm not saying don't do brain health, all the things I talked about, but be realistic on what it can and cannot achieve is what was really the take-home message. I already talked about the monoclonal antibodies for amyloid. They're actually doing the very same studies on people who have Alzheimer changes in the brain, but no symptoms. So there are now large, huge prevention trials going on that may answer that question and say, let's not wait for you to get symptoms. We're going to treat you before you have symptoms. So that is ongoing now. So I'm saying to you is do the brain health strategies, wait a couple of years, and we're going to have a better answer than the one I just gave you.
And the second part is, if you do those tests that you want, either the spine tap or all these other tests, is it covered by Medicare?
Yes, it's all about codes. You remember I smiled and I talked to Dr. Evidente. It's all about ICD-10 codes. Professor Coleman has a question.
No, just a clarification, Dr. Sabbagh. So for now, the so-called anti-amyloid infusion therapies, what population of patients are eligible for those to remove the amyloid from the brain?
So you have to have symptoms of memory loss, mild cognitive impairment, mild dementia. You have to demonstrate they have amyloid more than the blood test, so PET scans or spinal fluid. You have to check their MRI to make sure they have no microhemorrhages, and then you have to check their genetic markers. So it's only a selected number of people. It's not everybody. In fact, our estimates are only 20% of people walking into our clinic will be eligible for these new treatments.
So we can do something about amyloid nowadays. Then
Yes.
it's not like we can't do anything.
No,
right?
no,
We
no.
can do something.
Yes.
And so is that needle being moved earlier and earlier in the
Yes.
future? So for
Yes.
instance, you talked about screening, patients in the future. You don't have symptoms yet. You're in the
Yes.
preclinical stage. Would you foresee that in the future we would offer these anti-amyloid infusion therapies for patients with no symptoms, no MCI? They just have the markers of Alzheimer's in their brain or in their blood tests.
The answer is very likely yes. There are two studies going on now called the A345 AHEAD study and the Trailblazer ALZ4 study. These are people who are biomarker positive, meaning they have demonstrated amyloid and possibly tau in their brain, but there's normal, meaning no clinical symptoms. And they're getting these anti-amyloid treatments now. Those clinical trials include thousands of people. Those studies will read out in the next 2 to 3 years. And if they're positive, that's exactly what we're going to do. We're not going to wait for you to get symptoms. We're going to treat you before you have onset of symptoms. So we'll have an answer.
That's wonderful, because as a follow-up to the gentleman's comment or question a while ago, one reason to measure both alpha-synuclein and amyloid and tau in patients that are being screened for these degenerative disorders is that most likely we will intervene for all these disorders.
Correct.
So we want to know if you have amyloid. We want to know if you have tau. We want to know if you have alpha-synuclein. In the future, maybe, I don't know when that future will be, 10, 20 years from now, maybe more, maybe sooner, is to intervene early before the symptoms come up.
Yes.
And maybe that is kind of preventative in nature.
Agree.
Okay.
Professor.
First of all, I would like to congratulate you on a outstanding presentation.
Thank you.
As usual.
I want to address something that you did not say.
Yes.
And, when any of us go to a doctor and he makes a diagnosis, what you want to hear him say is, I can cure that. If you have an ulcer, I can cure that. I mean, the number of things that a physician can cure is countless. But Dr. Sabbagh did not say appropriately that if you go to him and he diagnoses Alzheimer's disease, he cannot say, I will cure you.
Yes.
And why is it that he cannot say, I will cure you? And the reason is that the research that I do and many other people do has not yet given him the answer that would let him say, I can cure you. And now I just want to make a comment that may be upsetting to some of you, but it's the truth. And that is that the research that we do in Alzheimer's disease has been totally decimated within the last few months. Laboratories that do work on Alzheimer's disease to provide Dr. Sabbagh with the information that he needs have been shut down. People have been fired. And this is something that is not helpful in terms of dealing with Alzheimer's disease. I also want to comment sort of in passing, and Marwan, you touched on this somewhat in your talk. I would be willing to bet that, I don't know what the percentage would be, but I would say at least 20% of the people in this room already have Alzheimer's disease. And it's in this early stage that Dr. Sabbagh talked about, the stage in which nerve cells in your brain have already been destroyed, but not enough to make a real difference in your day-to-day activities. And this is something that keeps going on and on and on. So this is a stage at which we want to be able to diagnose Alzheimer's disease. We want to be able to diagnose it at the very earliest stages. And one can debate about what age that might be. Dr. Sabbagh mentioned a rough period. I would like to say that basically the brain starts to be destroyed about 50 years before there's a clinical diagnosis. But that the number of years really we could discuss, doesn't matter. The point is to detect the disease before it has started to affect your behavior and to then cure the disease, halt the progression of the disease. Once the nerve cells have been dead, you can't reverse it.
Right.
But at least halt the progression of the disease before it has reached a point where it has any effect on you, so that you could lead the rest of your life with Alzheimer's disease, but never having any deficits because of it.
Thank you, Professor Coleman. I
So-
want to opine.
Excuse me, Marwan. I want to say one more thing.
Okay.
that might be, I would like to ask some people how old you think I may be. And I'll give you a hint. I'll bet I'm the oldest person in this room. I'm 97.
Wow. Yeah.
All right.
That's amazing.
Yeah.
Wow,
Yeah.
that's amazing.
So, thank you, Paul. Professor Coleman makes a lot of points. Let me just add one thing to that. In my lifetime, I hope we will convert Alzheimer's from a terminal disease as you know it to a chronic disease. This is a diabetes of our lifetime, HIV of our lifetime. The idea of curing it means you took it out of the brain as if it was never there. That would be reversing a process that's been going on for at least 20 years. We're not, that's probably 1 or 2 generations from now. I'm not sure we're going to get there anytime soon, but we will make it a chronic disease. I tell everybody I want to make Alzheimer's annoying, not life-threatening. And so our first milestone is to be able to make it a chronic disease, not a terminal disease. So we're on our way.
So do you think the cure will be, let's say, stem cell therapy maybe, or nerve growth factors?
I think we're going to cure it by preventing it. So what it's going to happen is people think of Alzheimer's, with all respect to this audience, as an old person's disease. That's how everybody perceives Alzheimer's, as an old person's disease, because most people get it are in their advanced senior years.
Diagnosis.
They get their symptoms in their advanced senior years. And yet we know the changes are occurring in their middle age.
Sure.
So what we really want to do is reverse engineer our approach to be able to detect the disease in middle age and then create a process to prevent, delay, or postpone you from getting symptoms. So that is the future, is prevention, not cure.
Which is the same approach we're trying to do in Parkinson's as well.
Same,
Yeah.
yes. Yes, yes.
I have 2 questions, if I might, and maybe a comment from each. Dr. Evidente, I've been told that I have non-motor dominant Parkinson's. There are many ways to cut it up and call this and that. Motor symptoms, non-motor symptoms. Most of my symptoms are non-motor, and I have some cognitive, I have some mood. My question is it possible to say if one is primarily motor versus non-motor, that one is more likely to develop dementia on one side or the other? Is that a possible thing? Because while we're getting better at diagnosing, prognosis is still a very difficult thing. And so everybody's looking to see, how am I doing relative to my cohort? So can you say if I have more non-dominant, I'm more likely to have dementia than have motor dominant?
Well, first of all, practically every Parkinson's patient has non-motor symptoms. So I've yet to see in my practice, I've been in practice for almost 30 years, a single Parkinson's patient in my practice that has no non-motor symptoms, all motor. The answer is 0, right? And then the second thing I want to say is Parkinson's doesn't start with motor symptoms. It starts with non-motor symptoms. Right. So this is the so-called non-motor stage, or the prodromal stage of Parkinson's. You have no tremor, you have no slowness, you have no rigidity, you have no shuffling, you don't have the poker face yet. And what do you have? You have REM behavior disorder, meaning you're dream acting. You might have constipation, you might have sleep issues, you might have cognitive issues. And so in answer to your question, those that have prominent cognitive non-motor symptoms in the prodromal stage of Parkinson's most likely will develop dementia earlier down the road when they're in the motor stage. So you don't get demented in Parkinson's in the non-motor stage. In fact, when somebody develops dementia from the get-go, we say, ooh, that's probably not Parkinson's. I'm going to pick Dr. Sabbah's brain. If somebody has Alzheimer's, so-called Alzheimer's dementia, but also has Parkinsonism almost at the same time, is that Alzheimer's disease?
No, that's Lewy body dementia, and it's very common. Lewy body dementia is actually the #2 cause of dementia, and I happen to know one of my patients with that condition sitting in this audience. Lewy body dementia is distinctive from Parkinson's and distinctive from Alzheimer's. It is characterized by fluctuations, hallucinations, acting out dreams. The Parkinson's less tremor, more shuffling.
Sure.
And it's a tough condition. And if you actually start to coalesce the diseases into proteinopathies, if you actually look at Parkinson's disease and Lewy body together, synucleinopathies are now #2 after amyloidopathies. So amyloidopathies, 7 million, synucleinopathies, 2 million. So it's very common.
Yeah.
Very common. In fact, it's the most common thing that nobody's ever heard of until Robin Williams had it. Ted Turner, if you know Ted Turner from CNN, he has Lewy body. If you remember Casey Kasem,
Yep.
he died of Lewy body. A lot of people have Lewy body. It's much more common than you think it is.
And so many of these patients make it to my practice because of the
Yeah.
Parkinson's bit, right? And
Right.
so, and then I kind of break the news to them. Well, you know, your father or spouse has a lot of hallucinations, has a lot of delusions, lots of REM behavior disorder, and now has, you know, cognitive issues and this Parkinsonism, you know, onset almost at the same time. This most likely is DLB. So aside from the amyloid PET scans and the blood tests and the CSF tests for Alzheimer's, I also do the Parkinson's workup, right? So what is the so-called Parkinson's workup? So I do a dopamine scan or DAT scan. So patients with pure Alzheimer's, and yet they have a little bit of Parkinsonism because of aging, because of orthopedic issues. If I do a DAT scan or dopamine scan on those patients, the DAT scan is perfectly normal. However, if the patient now has dementia with Lewy bodies, right? If I do the DAT scan, the DAT scan will be abnormal in this patient. So based on what Dr. Sabbagh just mentioned, the clinical features plus an abnormal DAT scan, and then with a neuropsych test, and the neuropsych test surely shows, you know, features of dementia with Lewy bodies, not so much the Alzheimer's pattern. Then we say, boom, there you go. It must be DLB.
Alzheimer's is a type of dementia, and the dementia that folks get with PD is a type of dementia. Are they very different?
Very. So Alzheimer's is the most common type of dementia, has no motor symptoms purely. The second most common type after dementia is not stroke or vascular. That's what most people think. It's actually Lewy body. Lewy body dementia is very common. 20% of all people with dementia have Lewy body. And it is the hybrid of Alzheimer's and Parkinson's. And then on top of it, Parkinson's people, if they live long enough, and many of people in this audience have had Parkinson's for years, decades. Parkinson's dementia is an advanced, it happens in your later stages of a Parkinson's disease. So you can either have Lewy body where the Parkinson's and Alzheimer changes come together, or you can have Parkinson's dementia where the dementia comes much later, and they both have alpha-synuclein in their brain.
No.
Yeah, I would agree with that. I would agree with that. Their features are very different. I mean, you know, this is our day job, Dr. Evidente, and my day job. They have different flavors. They have different feelings, different presentation, different symptoms. And that's, he's a Parkinson trained neurologist. I'm a dementia trained neurologist. That's kind of where we can, in 5 seconds, we can pick it apart.
Now, isn't there also co-pathology in the sense that patients with Parkinson's may develop Alzheimer's, or patients with dementia with Lewy bodies may develop Alzheimer's?
So in Parkinson's, 50% of people with Parkinson's dementia have Alzheimer's.
What about DLB, dementia with Lewy bodies?
DLB, it's about 80% of people with DLB have both Parkinson pathology and Alzheimer pathology. It's about 80 to 90%.
And this we only got wind of after now this FDA approved tests are available, the
Correct.
amyloid PET scan
correct.
and the blood test and so on and so forth. Now, as a follow-up to that, currently the so-called anti-amyloid infusion therapies are exclusively being given to Alzheimer's patients or pre-Alzheimer's patients in the MCI stage.
Yes.
Can we offer, therefore, this anti-amyloid infusion therapies to Parkinson's or dementia with Lewy body patients with positive amyloid PET scans?
This is such an important question that the NIH has actually commissioned a study to determine whether giving these treatments for people, because that will only take care of the amyloid, right?
Right.
But that study is actually going on because a lot of people are asking that question because so many Lewy body patients actually have Alzheimer changes. Can you safely and responsibly and effectively give Alzheimer treatments for people with Lewy body? The answer is we are investigating it. We don't have an answer for yet.
But do you have any anecdotal experience on that?
I don't. I know you sent me a patient and I wasn't sure what to do with them.
Actually, I do.
No, you sent a patient to
I
me.
know, no, actually, I do.
That was my your patient.
Actually, when you rejected the patient, I sent the patient directly to an infusion therapy. So,
Okay.
Yes, go ahead, please.
Yes.
There's short-term memory loss. And I can remember the address that I had when I was a kid. But I can't remember yesterday what I did. Is it time to get checked for Alzheimer's or dementia?
1,000%. You should, yes, as soon as possible. That is kind of the tip off to Alzheimer's changes, is that kind of short-term forgetfulness. Remembering what you did when you were 6 years old is a different part of the brain. Remembering what you had for breakfast is separate from what you did at 6 years old. So if you cannot remember yesterday, you may be already on your way to having something that needs to be addressed as soon as possible.
Do all Alzheimer's patients present with memory loss as the initial symptom, or are there other forms of Alzheimer's with no memory loss in the
Dr.
beginning?
Evidente, that is awesome. The answer is very nuanced and complicated. Most people remember Alzheimer's as forgetfulness, right? You're going to leave your car, you're going to walk out of the community center, you go to the parking lot, you can't remember where you put your car, okay? So forgetfulness, repeating yourself, misplacing glasses and keys, that is the typical forgetful form of Alzheimer's. The second most common type of Alzheimer's that is still the same disease in the brain, plaques and tangles, is a language form where you can't remember the words. We call that logopenic progressive aphasia. And the third, which is a very rare condition where you actually look like you're blind, you can't see, is a rare condition called posterior cortical atrophy. All Alzheimer's, but instead of being the memory version, it is the language or the visual version. There you
go.
Most 9 out of 10 neurologists couldn't figure that out.
Yeah, because I'll probably send you a patient very soon that presents with just the language impairment in the beginning.
Logopenic.
Exactly, and then I did an amyloid PET scan, and the amyloid PET scan was positive, and the
logopenic.
p-tau 217 was elevated.
Logopenic.
Yeah.
Yes.
Now, you say also the sensory deprivation is a big issue. What about the fact that excuse me, what about the fact that my sense of smell went away years ago?
So that's a little worrisome. I will tell you that loss of smell and taste is a very early finding in people who are developing Alzheimer changes. That's a worrisome finding.
Just as in Parkinson's, though.
Just in Parkinson's, right?
Because he has, because most of the people in the audience have Parkinson's as well.
Right. So let me in medical terms, when Dr. Evidente and I share things, we talk about sensitivity and specificity. the loss of sense of smell and taste is very sensitive, but not very specific, because you can see it both in Alzheimer changes and in Parkinson changes. So that's what we talk about, sensitivity and specificity.
What about REM behavior disorder? Is that
So
more
that's-
common in Alzheimer's?
No, it's almost rare. So when I hear about REM behavioral disorder, that's a tip-off for Parkinson's or synucleinopathy or Lewy body.
Got
Very
it.
much of a tip-off.
Okay, what about, speaking of loss of sense of smell and taste, what about COVID? Have you noticed an uptick of Alzheimer's disease since the pandemic?
The answer is yes and no. We've seen a lot of more people with cognitive issues. COVID can actually cause cognitive impairment. It does not trigger Alzheimer's. All the data right now suggests that you can get your own cognitive problem from COVID, but it's not Alzheimer's.
Including the so-called long COVID, right?
We're actually doing a study on it right now.
Yeah.
Yes.
Okay.
Yes.
You just said, I love words. You just said a very interesting word. And as a demonstration of my short-term memory, I heard it and I started writing it and I got 2 syllables. I couldn't remember what the rest of it is. But my real question is, could you say something about how music has been able to reach demented folks who've lost the use of language?
Yeah, so music therapy and music strategies are very popular and work well. We can use music therapy for behavioral management, meaning reducing agitation. We can also use it because some people can't remember the word, but they're stuck on finding the word. And I will tell patients to sing it. And sometimes if you sing the word, it will come out when you can't speak the word. So that is a workaround strategy that we often, doesn't always work. I want to be very clear. It's not always successful, but it's successful enough that we recommend trying it from time to time. Yeah. Yeah.
Now you spoke about the anti-amyloid infusion therapies. You spoke about the plaques and tangles.
Yes.
And we can do something about the amyloid plaques.
Yes.
What is ongoing with the tangles, though? Can we do something about the tangles in the future?
Yes. So funny, I was just in Chicago yesterday meeting with companies that are developing tangles. So we talk about amyloid, tau, plaques, and tangles. You've heard a lot about targeting amyloid. You've not heard a lot about targeting tangles or tau, because tangles and tau are actually inside brain cells. So it's hard enough to get something into the brain. Then it's even harder to get something inside brain cells. What is tau at the end of the day? It's a protein, what's called a microtubule stabilizing protein. It helps these other proteins called microtubules stick into place. When they get chemically altered, the cells literally fly apart because those microtubules disentangle. So the idea is if we can give an infusion of a drug that binds these tangles, then they won't spread, these tau, it won't spread throughout the brain. And I will tell you, we've been trying. Tau-based approaches just have not been that successful over the last 5 to 10 years. Been multiple failures, multiple shots on goal, multiple targets. They just haven't worked that way.
Well, just as there were multiple failures for amyloid in the beginning,
Correct.
right?
That's
yeah.
correct.
So we're getting there.
We're getting there.
So the future is to target both tau and amyloid,
Absolutely, 100%.
and maybe alpha-synuclein too.
And alpha-synuclein, 100%.
Very patchy memory, to say the least. I mean, I can remember our wedding day a little bit. That was only 45 years ago. And a few other things, little things like that, I can remember, but other things I just completely. I mean, my wife will say, she'll say, I told you that yesterday, and I'll argue with her for 20 minutes saying, no, you didn't. And she'll say, I did. So my memory is very patchy. Any idea why it's so patchy?
And you have hearing loss and you have smell and taste loss. I'd go get it checked, please.
Really?
There you go.
Short-term memory plus hearing loss plus sensory loss plus smell, I'd get it checked. I wouldn't wait.
Yeah, questions in the back.
Question is, the scientific side about it, that's great. I'm wondering, with this gentleman speaking, we live with a parent with Alzheimer's, and she's 90, has a lot of memory loss, losing things, all the symptoms. But at this point, what's it going to help us to get it checked?
So if she's kind of fully lost her independence, and you're managing her care, she's probably already kind of slipped into the moderate stage of dementia, not even the mild, in which case we would never do these treatments, and getting all these tests wouldn't necessarily change the outcome because we're not going to use these infusion treatments. Those treatments are only for people with very, very, very mild beginning of symptoms, the ones I've been talking about.
Okay.
So you could make an argument that you really don't need to get it checked, but the symptomatic management is important, right? So we can help boost the memory a little bit. We can help with the behavior. We can help with the sleep. We can help with a lot of things that could help her quality of life and your quality of life. Because I can tell you're a caregiver, and I can already tell you're stressed out, and I understand that because that's my day job. I get you. But there are ways to help her without necessarily doing the infusion treatments. We have other options.
Okay, and then being related, her son, is it something that you could check already in our 60s to see what's coming?
Yeah, so that's a very complicated question. I assume you both don't have memory issues. I'm just assume that for a moment.
Not really.
But you know your mother has, and mother-in-law, your mother has Alzheimer's. I got that. So we know that statistically your husband's risk is high because he has a first-degree relative. Higher because he has a first-degree relative. But what you're asking is, should you go get all the testing for risk? And the answer is that genetic markers, we do not recommend people who are asymptomatic from checking his risk on the basis of genetic markers, because Congress passed a law in 2008 called the GINA Act, the Genetic Information Non-Discriminability Act, okay? So if you went out and got your APOE genotype, you could, and it comes back with an E4, you might not lose your ability to get healthcare insurance, but you could lose your ability to get long-term care insurance. So we do not recommend testing of people who do not have symptoms. So the way you get to the answer is proxy testing your mother-in-law, your mother, right? You test her, and if she has risk, then you know what your risk is, and that's how we get to the answer. But routine testing of you, the answer is we don't recommend it yet.
But it's routine testing for the gene. What about
Gene or biomarkers, we would not.
But didn't you just say in your slides a while ago that at some point we want to measure, let's say,
Eventually,
p-tau
but that's not the
217?
current. Yes.
Okay, so
Yes.
that's the future.
That the answer is we do want to. You're no question about it, and
Right.
you said it's correct, but we don't recommend it yet.
Got it. So that's the future.
That is the future.
Now, are there cases where the p-tau 217 can be falsely elevated?
The sensitivity and specificity are good. That's why the AUC is so important. If it's a little elevated, I don't chase it. It has to be probably double normal before I chase it.
And is that specific to Alzheimer's?
Yes.
Got it.
Yes.
Is one of the Tangle therapies potentially Posifen or butanetap, if I say that properly?
Look at you, Posifen. Wow. You're reading good science, by the way, sir.
Well, I looked at it for Parkinson's a long time ago. I've been following it a long time, and there's a potential for a family member to
So
get in a trial for that. So 'cause
I'm
she has Parkinson's and Alzheimer's pathology. So
I shouldn't disclose this, but I reviewed the NIH grant for Posifen. So when I smile, it's because I was reviewing that grant 20 years ago for, so that drug has been around a long time. Very safe, very, very, very safe, very well tolerated. I think has a shot of working for both Alzheimer's and Parkinson's based on the science that I saw. So yeah, but it hasn't moved, it hasn't gotten approved, hasn't moved forward or not. So I'm just admiring your, so that's deep science dive. That's not a little science dive. That's deep science dive. But I agree with you. Big fan.
One back here. Hold on one moment.
One there in the back.
Yeah.
Dr. Evidente and Dr. Sabbagh, thank you for today. Could you speak very briefly or touch on ischemic dementia and temporal or frontal temporal dementia? And are there hereditary or ethnic factors and how they differ
So
from Alzheimer? Will they turn into Alzheimer's?
ischemic dementia is also known as vascular dementia, and that means you have either strokes causing your cognitive issues or severe white matter disease or degeneration of the, you have a lot of vascular changes in the brain. Those are easier to detect than Alzheimer's because you can see a lot of those changes directly on an MRI, and an aggressive implementation strategy can really arrest that progression. It turns out that vascular dementia is probably number 3 on the list of causes of dementia after Alzheimer's and Lewy body. Frontotemporal dementia is a cause of dementia that happens in young people. And you need to know that I know I'm in Fountain Hills, Arizona. My definition of a young person is below age 65, okay? I don't even give you a break until you're 80. Then I'll give you a little bit of a break, okay? So I say this to you, so when I see young people with dementia, it's either Alzheimer's or frontotemporal dementia. And then yes, your question is really, really on point, is that almost all the latest data on frontotemporal dementias, most of them have a hereditary component. There are multiple mutations. There's C9orf72, FUS, progranulin, TDP43. Those are now well-described targets on genetic markers. But so the frontotemporal dementias is really getting a lot of really sophisticated genetic analysis.
And just to clarify, the amyloid PET scan is negative for
It's
those
negative.
two conditions.
So frontotemporal dementia and vascular dementia would have negative amyloid PET scans, yes. And I want to say to you that frontotemporal dementia does not look like Alzheimer's. It's not forgetful. They either have severe language impairment or severe behavioral impairment. Those are the two features of behavior of frontotemporal dementia. I will never forget one of my patients who I have in my practice now, was in his late 60s, and he bought the whole African princess scam, sent the scammers in Nigeria $200,000 before the family said there's something going on here. And he's still convinced that there's a real woman on the end of that scam. And we in fact had to take away his credit cards and everything. So they have impaired decision-making, they have impaired executive function, they have behavioral issues. He was very impulsive. I mean, a very unfortunate case. So yeah, I have those patients in my practice, but they tend to have language issues and behavioral issues.
Now, you mentioned that some of the risk factors for Alzheimer's are those vascular risk factors.
Correct.
So how frequently do you see vascular dementia with Alzheimer's disease?
Yeah, so you know, MRI, you would see the vascular changes, and it's not that rare. I would say probably an overlap by a good amount.
Okay. And then would the memantines and the rivastigmine work for vascular dementia?
Yes,
Got
they
it.
would, yes.
I was about to make a joke, but I probably shouldn't. Executive function, do you think Trump could get a test? What is the prevention then that you're looking at as the intervention of choice? What can we do to prevent?
Yeah, so what I would say to you is do it all, okay? Exercise, eat low saturated fat with a lot of olive oil and monounsaturated fat, sleep well. Do not underestimate the power of sleep. Sleep is awesome. It's also one of the existential enemies of the Parkinson's world, right? Is sleep disturbance. Avoid falls, blood pressure management, COG-STIM. There's a lot of things you can do. They will help your brain health overall. The question is, can they mitigate Alzheimer changes? And that's still being to be
The sooner the intervention, the better, right? So
yes.
how soon should that be, and who will listen at appropriate ages, like 20 and 30?
I'm 59. I'm going to turn 60 this year. And I've already been doing it for years because I believe that the way you prevent it is to start in much, much earlier. So the answer is start today.
Yeah.
Okay.
And it's never too late.
I'm talking about age. I mean,
I'm
maybe the
saying
people that should be
you should
listening
be doing
to
it from throughout his lifespan.
Right, right.
You
But
know-
who is putting that out there? Who is putting that out there for our grandchildren?
Brain health is a big area of focus and interest. A lot of people are really, really keyed into brain health and what we used to call anti-aging is now called senolytics and longevity science. And so those are separate phenomena, but they're kind of often intermixed. So there's a lot of interest, and you'll see more and more of that as time goes on.
Yeah. So on the Parkinson's side, we're still thinking toxins, maybe a role of some kind. On the Alzheimer's, not so much.
Yes, so it's probably an interaction between genetic and environment.
You know, I have a patient recently that I saw in my office that presents with cognitive impairment, but mainly more frontal lobish.
Yeah.
And then he has 20 supplements that he takes.
Yeah.
It's really a long list of supplements and
Yes.
maybe just one medication. So I
Yes.
said, wow, that's a lot of supplements. So
Yes.
the question is, are there supplements that can harm you cognitively? And are there supplements that can help you cognitively?
So supplements are very popular. So in this segment, every other commercial is Prevagen. Every other commercial, right? So you can't
Right.
watch TV for
Right.
5 minutes without seeing a Prevagen commercial. What I can tell you about Prevagen is this: it's perfectly safe.
But is it effective?
Did you hear what I said? It's perfectly safe. I didn't say anything about effectiveness. In fact, they got fined by the FDA $70 million for false advertising. And what did they do? They wrote a check and kept going. They're like, fine, here's $70 million. The cost of doing business. That's exactly what they did. There is not a shred of evidence that works, but it's very popular, very popular. So what I'm trying to say to you is that supplements are touted as the magic bullet to cure all things. And I can say to you is that for mostly, they're safe. But the FDA has a regulatory standard called GRAS. FDA has a standard of supplements. GRAS is generally recognized as safe. And this regulatory standard for a supplement is it has to be as safe as a potato chip.
Which is not very safe.
Right. That's it. It has to be as safe as a potato chip. The FDA does not require supplements to have any shred of efficacy, quality control, manufacturing standards, good GMP, good manufacturing practice, nothing. All it has to do is it has to be safe as a potato chip. So the reason I say this is that it's very, very unregulated. Most of the time, for the most part, it's safe. Very few things cause harm, but very few things can be proven to have benefit either.
Okay, so I'm going to twist your arm. So give me one supplement.
Huperzine.
Huperzine. There you go.
Huperzine A.
Huperzine.
200 micrograms can make your memory. Huperzine. Huperzine.
So the pharmacology of huperzine is very similar to the medicines we prescribe, right?
Absolutely, because it's a natural clone. It's a natural Aricept. It works like Aricept.
Now, if I'm not mistaken, isn't ginkgo biloba being prescribed for cognitive issues in
Ginkgo
Europe?
biloba is one of the most popular supplements for memory issues. And we still have been recommending for decades. And yet there was an Austrian study by a pure ginkgo biloba supplement called EGB 761 EBW Pharmaceuticals, which showed that it was tried and it had zero benefit, and yet ginkgo is still around.
Okay.
Are we running out of time?
Last two questions.
Yes.
Is there any evidence, anecdotal or otherwise, in your experience that chemotherapy can cause the early onset of Alzheimer, not Alzheimer's, of Parkinson's?
Yeah. So the answer is chemobrain is a real phenomenon. Chemobrain, intravenous chemotherapy can cause cognitive issues. It doesn't cause Alzheimer's. It causes its own cognitive issues, but it's not Alzheimer's.
And so can radiation.
And
to the
radiation
brain.
can too, yes.
Is Lewy body treated any differently as far as medication and exercise and diet than?
Yeah, so I have to tell you, I have a lot of patients in my practice with the Lewy body, dozens and dozens. I actually, technically speaking, the answer is no, but the real answer is yes. I say this to you, so we use the same medication we use in Alzheimer's and Parkinson's to an extent, because the other thing that people don't talk about with Lewy bodies, they have very unpredictable responses to medications, very, very unpredictable responses to medications. I always talk about the Lewy body triangle. Parkinson changes, cognitive changes, psychiatric changes. Talk about the Lewy body triangle. So I might give you a drug to help your Parkinson's, as I did on my last patient on Thursday, and all of a sudden his psychosis, his hallucinations got way, way worse. So my point is you've got to think about the triangle. So we're very gentle. Things I wouldn't use, I would never use dopamine agonists in Lewy body patients. I would never use antipsychotics in Lewy body patients or most antipsychotics in Lewy body. So the answer is yes, we use the same meds, but the choice of meds is quite narrow and limited in Lewy body patients.
Okay, I think we have to wrap up. So let's give a warm round of applause to Dr. Sabbagh. And hopefully, can we invite you again in a year's time? Because there's so much
My pleasure.
ongoing in
My pleasure.
dementia field that I think in a year's time, you're going to give us a lot of new information.
Yeah.
Thank you
Okay,
for including
wonderful.
me. Thank you.
Thank you,
Wonderful.
Dr. Sabbagh, and thank you, Dr. Evidente.